Siobhan Russell. I am a master's nursing student at the University of Hartford. Um, I'm going to be going over my syllabus and how I came up with the idea of doing a clinical versus lecture, my educational theories to support my syllabus, an overview of my clinical, my school, and the demographics of my students, outcomes and objectives, and then a conclusion. So research has shown that there is a knowledge to practice gap, and only 28% of new grads are competent to practice safely. More hands-on learning experiences has been shown to be the best way to increase clinical competence. My personality leads itself to teaching hands-on skills. I love teaching hands-on, and I love teaching pediatrics. And this is why I chose a pediatric clinical rotation. So my educational theorist is Kolb's experiential learning cycle. I'm not going to go over this just for the sake of time, but we've seen this before in other classes. I how Kolb's experiential learning cycle can engage students in any of the four learning styles as categorized by Flemings and Mills. So the visual learners are going to benefit from watching a video, seeing graphs or charts. Um, an oral learner is going to benefit from a lecture. That's the abstract conceptualization that the Kolb's experiential learning cycle shares. The readers and writers are going to benefit from handouts with references for them to look up more learning. And lastly, the kinesthetic hands-on learners are going to benefit from hands-on care and demonstrations. So just some background for my course in the beautiful state of Hawaii. Um, I have junior level nursing students. There is a 1-to-6 ratio. We are at a hospital for special care. It's a subacute rehab hospital for chronically ill children with various disabilities. Our clinical is 7 weeks, 135 clinical hours, 3-credit course. There's going to be a lab component. Observational experiences are going to be part of it. My teaching strategies are going to be coaching, role modeling, group discussions during pre and post conference, and the students will be getting weekly evaluations. The demographics of my students, I have a diverse mix of mostly female students, ages 21 to 26, and you can see here their demographic makeup. So just as my students have to build week by week to gain their independence, as a new instructor, I use the weekly worksheets to formulate my outcomes and my objectives. Over these, I'm going to show you outcomes will lead to my course objectives. And my outcomes don't just my learning objectives don't just happen by themselves. By setting weekly ancillary goals, they lead to the mastery of my learning objectives and ultimately the course outcomes. So I'll just go over this very briefly. The students need to demonstrate a complete head-to-toe assessment of a pediatric patient, create a concept map illustrating their chosen patient's clinical diagnosis, but I want them to understand it in relation to developmental norms for that chosen patient. I want them to research and present a family-centered teaching session for a patient or a family, and they need to be able to perform safe clinical treatments in a pediatric hospital setting with supervision, um, weekly getting more independent. So just an overview of how our weekly ancillary goals leads to my course objectives and ultimately the course outcomes. So weeks 1 to 2, we're going to be doing skills validation, including a math test before they can give meds. Communication, this is going to be communicating with the team, their preceptor, me, each other, and providing therapeutic communication to their patient and their families. They're also going to be doing just very basic level personal care for their patients. Weeks 3 and 4, they're going to be getting at least 1 to 2 patients. I am going to be the role of a coach along with one-on-one assessment. The students will have a preceptor assigned to them to help with supervision. They will not be giving meds until week 6 and 7. So weeks 3 and 4, they're going to be increasing independence, providing basic care and vital sign analysis, along with focused assessments. These two things are going to form the basis of them doing a full head to toe. Week by week, they're going to gain confidence and independence in providing this care. Week 5, we're going to be in the field with observational learning experiences. Places like school health, community health centers that have adolescent medicine, and places like the WIC office at the health department are going to be some ideas of where students can be placed. We're also going to be doing concept map presentations during this week. Week 6 and 7, this is what I like to call putting it all together. The students will be getting, 3 students will be getting a full patient assignment of not more than 3 patients, and they're going to be doing full nursing care, assessments, documentation, and med passes for their patients. The other 3 are going to be doing educational teaching sessions. Week 7, we're going to flip flop, and the 3 that did teaching sessions are going to be doing full nursing care. Finally, evaluations and outcomes. The students will be having a skills lab final. They will be given an online course evaluation to evaluate the course and me as the instructor, and they will get a final clinical evaluation. So in summary, I want to reiterate the importance of decreasing the knowledge to practice gap. The next gen NCLEX is aiming to increase the clinical reasoning of the nursing students so they can illustrate what they know. Yet the AACN Essentials aims to increase the clinical competence of nursing students. Competency-based education is empowering students to show what they know how to do, not simply what they know. My references so much, and I look forward to hearing about all of your classes.